Good afternoon, everyone. So this is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Breastfeeding Week. And I request Marina ma'am to take over.
A very good afternoon to one and all, those who are attending online and offline. I'm Marina Elizabeth Alex, Assistant Manager Dietetics and IAPN Chapter Secretary. August 1st to 7th is observed as World Breastfeeding Week. This program is initiated and organized by the Institute of Reproductive Medicine and the Department of Nutrition and Dietetics, Madras Medical Mission, in association with IAPN India. IAPN India is Indian Association of Parental and Enteral Nutrition. It is an association formed by doctors, dietitians to enhance nutrition knowledge and practice at hospital and community level. Breast milk is the most safest and the most nutritious way to feed the babies. Today, we have informative talks by our eminent doctors to enlighten us on breastfeeding. So today we have Dr. Kundavi Shankar, who would give the welcome address. Dr. Kundavi Shankar is head of the department, senior consultant, MBBS, DGO, DNB, MNAMS, FICOG, diploma in reproductive medicine, diploma in advanced lab surgery, lead fertility consultant of Institute of Reproductive Medicine, Madras Medical Mission, honorary secretary, OGSSI from 2023. She is an academic secretary of TAP ISAR from 2022 to 2023. She is a fertility preservation committee member, recipient of IFS Achievers Award in the year 2023. She is a recipient also of ISAR Dronacharya Award 2023 as a MMM Fellowship Program Chairperson of Bosch Committee MMM. She has many publications in reputed journals, invited faculty in national and international conference. Over to you, ma'am, for the welcome address.
Thank you, Marina. Good afternoon. On behalf of IRM and Madras Medical Mission, the Nutrition and the Dietary Department, and IAPN Chennai chapter, we welcome all the faculty and the delegates in spite of the busy schedule they are here for the excellent talks and for the webinar during the Breastfeeding Week celebration and the awareness program. We have got three faculties, Dr. Shankar Narayanan, Dr. Jayashree, and Dr. Suresh, who's going to discuss about the practical issues regarding the breastfeeding things. Once again, on behalf of Madras Medical Mission and Institute of Reproductive Medicine, I welcome all the delegates and the faculty for this webinar. Thank you.
Thank you, ma'am. So we have, for this program, we have chairperson, Dr. Shubha Karthikeyan, ma'am, and Dr. Anjali Manoharan. They will be chairing the sessions. So I would like to just introduce them. Dr. Shubha Karthikeyan is DNB, FAAP, FRCPC. She has obtained from the Royal College of Certification in Pediatrics, Neonatal Perinatal Medicine from Clinical Fellowship from University of Calgary, Canada. She has obtained a diploma of American Board of Pediatrics from Children's Hospital of Michigan, USA, and she is a diploma of National Board of Pediatrics certified in the year 2000 from the Kanchi Kamakoti Child Trust Hospital, India. She has finished her MBBS from Chennai Medical College. She has certification from NRP, that is Neonatal Resuscitation Program, instructor current, and PALS, the Pediatric Assisted Life Support Provider. She has membership in so many associations like National Neonatal Forum, the American Association of Pediatrics, the Canadian Medical Protective Association, Canadian Pediatric Society, the Calgary Areas of Physician Association, Royal College of Physicians and Surgeons of Canada. And she has many publications to her credit. So I welcome you, ma'am, for the sharing the session. So we have Dr. Anjali Manoharan. She has finished MBBS, MRCP, CH, PGPN. She has finished MBBS from Pondicherry University of Post-Graduation in the year 2020. She has Sundaram Medical Foundation and associated in Triple M from 2022. She has special interest in preterm and newborn nutrition. So welcome you, ma'am, to chair the session.
Good afternoon, one and all. It's been an honor to be a part of this CME today, and an honor to introduce Dr. Shankar Narayanan. He is a working colleague with me in neonatology. He's one of the senior consultants here at Triple M. My association with him is right from college days. So he's a very talented physician with experience, as you see in his degrees. இது எப்படி மேடம் அங்க டிஸ்ப்ளே பண்ணாங்க இங்க தெரியுது அங்க தெரியல Okay. So with experience both from India and the West. So he's a physician from, with experience all around the world. His degrees, I should say, is as long as his name or even more longer. He's got a degree in pediatrics and neonatology from India, from the UK. He's got degrees in education. So he's a well-rounded physician as well as a very good educator. And if I don't mention his wittiness, you would see it in his presentations today. All his presentations do have a fund of knowledge, and on top of it, it's a very witty, humorous, session which you would all enjoy today. So I welcome Shankar on stage for his presentation.
Yeah, அதே மாதிரி இது.
Thank you, Shubha, for the kind words. So my topic is slightly different from what you're going to expect. So today we are going to talk about sorry.
நான் மாடல முன்னாடி போனாலே செட்டி ஆகும் இது லாஸ்ட் டைம்
You can hear me? Yeah. So we're going to talk about how men can support breastfeeding. So whenever we talk of someone supporting, for example, we have Dr. Hema Kumar here. Will he support me? What do you think? So the answer is it depends. So it depends on if I give him leave, he will support me. If I get him some coffee, there are other things, but coffee, he will support me. In a similar way, men are more likely to support something if it benefits them in some way, or is it helpful for them in some way. So we come to a couple of what we are going to do today. So we're going to look at what do men like. So in that way, we can make them support breastfeeding. How does breastfeeding help these likes? And what can men do to promote breastfeeding? And then is the man in the house as useful as the heart for the human body, or as useful as the appendix? We'll come to these sort of questions. So the first question we're going to come is, what do men like in life? So we'll start with someone. What define a good man? I mean, I don't mean Gandhi or Abdul Kalam. If they are looking for an alliance for you or your sister or something, what do you want in the man?
Sir, we can't see your slides, sir.
There's nothing else. What do you see? What is a good man? Caring. But how do you measure caring? I mean, he might come and say, but then he might not actually be caring. So it's difficult to measure caring. So what looks like caring initially might not be caring later. So, but what can be definitely a good thing which you can see and identify? Efforts. For example, if we ask, is Hema Kumar a good man? So what do you measure it as? So one thing we can say is education. If he's got a lot of qualifications, he might be a good man. Education is different from learning from actual life, but that might be something. But if he's well educated, but no money, then will you like him? So there are reasons why men like certain things, and that is the society. So money is success. So people value money. So if you say பையன் வந்து எவ்வளவு சொத்து இருக்கு, இந்த கார் வச்சிருக்கான், பைக் வச்சிருக்கான் அப்படின்னா, இஸ் மோஸ்ட் லைக்லி டு திங்க் நல்ல பையன். ஸோ அதனால மணி இஸ் சக்சஸ். And a man is worth money in the open market. So that is what a man is worth. So that is why men like money. So men like money because society likes money, not because the man himself likes money. So how does this come in the context of breastfeeding? I mean, the men generally have money, but they spend it on these things. So betting on Dream 11, poker bazi, IPL. Some use it wisely for investment, but many use it on the other things. So what are the economic benefits of breastfeeding? So we'll come to how much does formula milk cost? We'll ask the man here. How much is one dabba of, we'll not take names of formula because
Sir, it's not audible, sir.
so the very expensive dabbas will cost about 1,250, and roughly we need about 6 packs per 6 packets. 6 packs is different. 6 packs for 1 month. So that costs about 7,500. Is there any other cost to breastfeed, to bottle feeding? So we have to buy a bottle. We have to do sterilization. All those babies who are bottle fed or formula fed are more likely to require hospital visits, and therefore, if they are breastfed, they're likely to require less hospitalization, less infections, less cost of medicines. And if you think of what all is needed for cleaning a bottle, you'll see one, you need water. Now they're putting tax for water also. So then we have water. Then it has to be soaked in some in water with some soap in it. That soap is also expensive nowadays. And then you need a bottle brush. You need to spread it out on towels, which have to be clean. Then boiling gas is expensive. Electricity is more expensive, and it's going to get more expensive every year. And then there's also other steaming and all that will also cost quite a lot. So it makes a lot of economic sense to the man who values money to show that breastfeeding cuts down the cost of a lot of things in life. So what else do men like? So this is one. Men like sleeping. And how can breastfeeding help with men sleeping? So breastfed babies are like, okay, breastfed babies sleep easily. They're also likely to be less colicky, and therefore it's easy. You're sleeping and your partner, wife, who is sleeping next, and then baby starts crying, and then that's it. But otherwise, if it's a formula fed baby, you have to get up, hot water, cold water, make formula. So all that is quite expensive and wastes a lot of time. புரிய மாட்டேங்குது. அதே பேசலாம், அதை பார்க்கறதுக்கு. Not many slides. Also. Now it's come. Okay. One more thing which men like is continuity in life. So, you know, whatever affects continuity. So before a child is born, people like to travel. Papanasam pono, Kutralam pono. All that becomes difficult when you have to carry bottles and steamer and formula dabba and all that. But breastfeeding becomes travel is easy. Another thing is lot of, especially when premature babies are born, because of the stress in the family, lot of breakups happen. When in India we are forced to live after marriage generally, but in the West, lot of breakups happen. But with breastfeeding, there is better bonding in the family, and therefore this is a benefit of breastfeeding for the family. So what we have learned is, what do men like? How does breastfeeding affect these likes? And then we come to what can men do to promote breastfeeding? And then the last question will come again. So there is some evidence that breastfeeding is actually that fathers, when they're involved in breastfeeding actively, then the duration of breastfeeding or the duration of exclusive breastfeeding is increased. But the important thing is, for breastfeeding to be initiated, the mother's knowledge, mother's experience, and the mother's will to start breastfeeding is more important. However, for it to continue further, we need someone to support, and generally that's the father. So this slide on the left, on the right rather, shows that where fathers are supportive, breastfeeding, as a mother's breastfeeding practices keep improving through the course of time. However, when fathers are not supportive, then the rate of breastfeeding keeps on decreasing. And then in India, generally after the baby is born, the mothers go to their mother's place, and that is a headache less for the man. But that's not what it's currently also. See, 2016, about 56% of families were nuclear. So more than half the families were nuclear even in 2016. But in 2027, that's going to go up to about 2/3. So most couples are going to deal with the baby on their own without party's mother and all that. So what can fathers do to support breastfeeding? So one, you can play with the baby. So this is simple. How to play with the baby? I mean, you don't need any special skills. Just don't be frightening. Just talk nicely to the baby. And if you have any doubts, nowadays there are multiple ways to find out the information. Facebook, Instagram, Hema, I don't know, much more. Once the baby is with the mother, you can still participate in playing with the baby. You don't have to say, you take the baby and go and do something else. So still play as a family. Changing nappies. And this is something which men can do. This helps in supporting the mother in breastfeeding. So either you can change the nappies happily, or the dandakadane அப்படின்னு பண்ணலாம். But whichever it is helpful, I mean, whatever you think, as long as you change nappies, that is helpful. And when mother is breastfeeding, you can sit next to her and say, "Oh, well done, and I'm very happy that I'm not able, that I can use the money to spend on IPL, and you continue breastfeeding." Or you can leave and then watch IPL. And that is not the right thing to do. We should always support the mother in breastfeeding. You can also do these things. Make clean dishes. And these are things which can be done by anyone. Again, blogs, reels, everything is available on how to clean dishes also. So you can easily find out how to make tea. Well, you can make tea for yourself, or you can, so for a mother to breastfeed at the same time say எனக்கு tea அப்போ அப்படிங்க, it becomes a bit more difficult. But if you make your own tea, or better if you make tea for your wife also, that becomes even more easier. If you can cook, that's even more better. Even working men can help. So working men nowadays are mostly working from home, and but in India the general concept is, once we are working, we should not do anything more. But while working also, you can at least hold the baby. This may be a call center for say Bajaj Finance or something. You can talk to someone at the same time, baby can continue playing, or you can do some laptop work. You can feed the baby a bit later and still continue with your work. You can also do skin to skin care. I mean, that is a tattoo, the colon. And if you're more sort of conscious, you can do skin to skin care that way. So we looked at what do men like, how does breastfeeding help, and also what men can do to promote breastfeeding. So we come to the last question. This is the heart, and that is the appendix. So as far as breastfeeding is concerned, what do you think? Is man like the heart or like the appendix? Remember that if appendix inflames, it can affect the heart. So what do you, sir, have any ideas? But appendix is vestigial, but if it inflames, so the answer is probably something like the lungs. So mother is one lung, father is another lung. So with one lung also you can walk, you can probably run a bit, but with two you can run long, you can run a marathon. Again, like a kidney, one kidney is also enough, but with two kidneys life becomes a bit more easier. And if one is damaged or somewhat less, working less, then the other can take over. So this is probably more the truth about breastfeeding as such. So we talked about what do men like. We realize that men like money, sleep, continuity, and therefore breastfeeding helps in all three. We also saw what men can do to promote breastfeeding. So taking care of the baby, changing nappies, helping with chores, skin to skin care. These are things which men can do. And we have also answered about man is neither an appendix nor a heart, and more like a lung or a kidney. So supportive fathers, in summary, can be quite useful for continuation of exclusive breastfeeding. And unsupportive fathers can actually be very harmful, like an inflamed appendix, to the cause of breastfeeding. There are many ways in which breastfeeding dads can support breastfeeding mothers. And a family will benefit if both members participate actively in supporting each other. So we'll come to the last slide. Now, what is the relevance of Papanasam to breastfeeding week? If you remember, on August 2nd, Suyambulingam went to Tengasi. And actually it was on 3rd, he went on 3rd, but he said he went on 2nd. So Papanasam has some relation to breastfeeding week. So when there is a so when there is a test, when there's a breastfeeding is a challenge, and there is a lot of problems. So when there is a test, family is always the best. Okay, thank you.
Questions? ஆமா, YouTube link எல்லாம் சொல்லணும். Thank you, Shankar, for a wonderful talk. I think all the men folk will start looking at the YouTube and Instagram from today to learn how to clean vessels and, cook something before you find a partner, right? It's pretty scary, right? அம்மா வீட்லயே இருந்துடலாம் போல இருக்குல்ல. Okay, so any questions? Yeah, actually, in the unit பொறுத்த வரைக்கும் fathers have been so supportive actually. We've had fathers starting KMC, then mothers first. Like Esther and, Maitli. Father was the first person who did the kangaroo mother care. The mothers were very scared, but the fathers came forward and started doing it first. So we have pictures actually for all of that, but it's very nice. They start getting involved once the baby is born. A lot of fathers are like that. So I think all the men folk are having a lot of heart here. Like, unlike what Shankar said, they're not appendix, they do have a good heart. Okay, so any questions from the online people? How do we know? Sir, I know.
They are the ones who need to get the message.
Madam only. Antenatal counseling lay, they have to start. The involvement of the father with the child, la, Shankar?
They need to be sensitized.
Very much, very much. That's very true. Yeah.
Actually, the patients come postnatally. The fathers are only carrying the
50-50, I would say, madam. Now it's become 50-50. Mostly it's mother-in-laws, like our mothers at 60% and 40% of fathers. But you see more of fathers getting involved these days. Like a lot of both the parents working, we see a lot of fathers. And as Shankar said, it should be started right very early in life. That men take responsibility for everything in the family. It's not that you go to work, but women go to work and still take care of the family. So they do, yeah. Jayashree is ready, I think. Okay. Thank you, Shankar. So we'll, the next talk is from Dr. Jayashree Jayakrishnan. Jayashree is a very good friend of ours, like our Triple M team, because she was here before as a lactation counselor. And I know her for about 10 years now. She is a person who has multiple skills. Her basic is being a lactation counselor, and she has she's the founder and director of Happy Mom, where she has so much resources. I think all of you get a chance, go and log into Happy Mom. She has so much resources for breastfeeding mothers, different ways of feeding and all the, details you need to, feed your baby, and all the questions, answers, everything. She has details on it, and it's excellent work she does. And she is the first time in India to receive the IBCLC Breastfeeding Care Award. She's the pioneer presenting in ILCA international conferences. This is just not to say, but she just keeps learning new skills all the time. She's actually done a lot of work on birthing, water birthing, and then now she's doing something more. So, and her teaching on lactation counseling has really enriched a lot of people. Actually, I did a course after getting inspired from her about how useful lactation counselor is for a newborn, for a new mom, a first time mom. It's a lot of help for them that they can breastfeed their child without pain and they can enjoy it. That's a wonderful experience. And I got a lot of insight about it from Jayashree. And I think you're going to gain a lot out of her talk today. So feel free to ask questions at the end of the talk, and I will let her start. I welcome you, Jayashree, for the talk.
Thank you, Dr. Shubha. So kind of you to say.
Can't hear.
Can you hear me?
Jayashree ma'am, your voice is very low, ma'am.
Very low. It's 100%. Is it
Kindly increase your system volume, ma'am.
It's 100% actually. It's full on me. Can you hear me now?
No, ma'am.
Very
It's
low,
very
very
low, ma'am.
Is it audible?
Yes, ma'am. Now it's fine, ma'am.
It's clear? Very
Yes, ma'am. Now it's clear.
Or it's feeble?
It is, you can, if you can.
Money IT. Very little. Is it
Ma'am,
audible?
you can start sharing the screen.
I forward the PPT. Do you have the PPT? Can you hear me?
Yes, ma'am.
Yeah. Do you have my PPT?
I'm the technical person, ma'am. So I will ask the auditorium people once.
Yeah. So thank you, Dr. Shubha, for that nice introduction. And Shipulam, I always close to my heart, the chapel, everything. I miss the canteen. So, thank you for calling again. I'm actually very happy to present this to all my colleagues and audience over here. So the topic given to me is breast milk expression and feeding methods. I hope I'm audible. Am I clear? Can you please confirm once again?
Yes, ma'am.
Yeah, thank you. Oh, can I move the slides or do you move the slides? Yeah. So when I talk about breast milk expression methods, primarily known methods I will start about. So generally it's known about hand expression methods. Hand expression methods are being done reverse to what I'm showing to this image. This image doesn't move when I click it. Next slide, it just move the next slide. So what they generally a mother does is when I tell them to do a hand expression and come and we are seeing a mother after 4-5 days, we can see bruises on the breast. This complete like on the techi. This is where they do. They compress and they literally go towards the nipple and they take the milk off. Where there will be very hard bruises on the breast. So this is not the way of taking hand expression where many mothers will have a lot of milk that blockage and then they may lead to kind of redness and all breast pain. That's something very scary for them to continue doing this hand expression mode. So the real way of doing a hand expression mode is, can you show me the previous slide? Yeah. So you have to first gently massage breast just to make it comfortable for you. It's more for a tactile stimulation to say. When we touch something, we get ourselves triggered. No, for that reason we are doing that massage. After that, you can keep your hand placed 360 degrees around the breast in any way between your thumb and your first finger. And you have to go towards the chest first and compress together and then relax. So when we say compress together, most mothers, I'm saying mothers, attenders, whomever we teach, they tend to pull off the skin part, not the muscular part. This is very challenging between a medical professional and a non-medical person to acknowledge the difference between a compressing a muscle or compressing a skin, the tissue part. So most of the time when they do compress from the tissue part. They say, I'm not able to see any drop in my breast. There's nothing is there. That's what they mention. So we have to literally teach them the difference between the muscular part where they have to compress compared to the tissue skinny part where they do. Once they start to acknowledge it, this is something very easier method where in 2 minutes, 5 minutes, they used to take so much of ml of milk. But unfortunately, the physical knowledge of the mothers, I have to put it in that sense. Physical knowledge is everyone knows the benefit of breastfeeding, irregular of the gender and generations, everyone knows it. In spite of it, why they are not able to accomplish is the physical knowledge among the partners. The previous speaker was wonderful. I was literally loving the slides what he had shown. But both men and women are equally not physically fit enough to move with the process. That's what the challenge we are facing it now. When they are telling them to take hand expression, my hands are paining, I'm not able to do it, so it's actually hurting for me. That goes from the attender side also, they're not able to do it. So what happens then? They go with another option. Okay, fine, I'm not able to do it consistently. Maybe you find once or twice, but it's not a consistent way I'm able to do it means, then we have to go with the next method which they can adapt. So next slide. Next slide. Next one. Okay, then they go with this breast pump. So breast pump, there should be a judicial use of breast pump. It doesn't mean when we say a pump, they can use it lifelong, every time. No, not at all. For what reason we are starting now? And when we are starting, when we are going to wean from the pump, also it should be discussed with the mother. And if it's so for that particular reason, and based on that, the pump what we are buying, the brand, the cost, the flange size, everything is being discussed on the base of the reason why the pump is bought. So most of current generation, what we find is the reason for pump for the initial days. I'm talking first deliver. I'm delivered today. In next 2-3 days, when they don't see milk in the rice, they immediately want to pump. That is another negative aspect of them, because when they pump, they don't see milk still more. So they get still more kind of negativeness, like, when I hand express, I don't see milk. When I pump also, I don't see milk. In all social media, I could see liters of milk is being taken out, but how come I'm not able to take milk? So the timing when the pump has to be started is not being educated to the couples. And also from the medical practitioners also, the pump knowledge is there, but what kind of pump, when it should be started, how long it should be done is not being evenly informed to everyone. So for in case when they say generally a pump should be bought, they see to the reviews first. When they see to the reviews and they get a pump, they don't see whether the flange size fit for them, whether it will hurt for them, whether they should go with the next flange size. And these aspect is not being discussed properly. So that pump will become a failure thing for them. So ultimately what they projected as pump is a failure one. It doesn't work for me, or else I am not producing much. My lactation supply is less, so it doesn't produce much. So I have to get the help of galactagogues. They tend to get themselves deviated from it. So what I'm trying to say is, first reason out the pump, and then we have to see for how long they need to use it, and then we have to choose the pump which they have to buy. So when you're going to buy a pump, what are the instructions you're going to see? I'll be showing in the upcoming slides. Yeah, next one. Next one. Next. Yeah. So this is a pump which been seen not commonly now. Earlier days it was very common because it cost about 150 rupees to 300 rupees. Very easily available everywhere. But unfortunately, this is being banned now because the part receptacles where this breast milk falls, each and every part of the pump has to be sterilized. Here in this pump, the balloon part can't be sterilized. So you can't sterilize 100%. The suctioning power will be very, very poor into it. And the mothers get to an impression that my supply is less with this. So that's the reason we tell them not to buy this pump at all. As of now, this has been a banned one, but still we were able to see in remote places, not much in the city. Next one. Manual hand expression. This is the first choice any mother will tend to choose. The reason for them to choose is the cost. First thing is the cost. Second thing, they have more confidence that they can. Yeah. So second thing, they think that they can switch over to breastfeeding and they'll be doing only breastfeeding. So no need to spend much on electrical breast pump. So let me start with the manual pump they use. When you choose a manual pump, the flange, the conical part, the standard in manual breast pump. You don't get variations in manual pump. This is a standard one which you see it, which may not fit one fit size for every mother one. Second thing is the way they press. They shouldn't press completely. It should be like a stimulation mode for 2 to 3 minutes, and then they have to go with a complete compression. This certain mothers get to know the knack of it and they do it really well, where they're able to benefit with it. But certain mothers not able to get to it, they find it to be disappointing. And another thing of this manual pump is, as they have to do for a constant time in case if it's a preterm baby, or even if it's a twins, they're going to get this kind of a pump, they easily land up into decoherence. That is, your wrist side, the abductors of the thumb side will start to ache a lot. They start to give a complaint, my wrist is paining, my thumb side is paining, I'm not able to do continuous pumping. So when we are telling about the pump, we have to talk so much that if you get this, you have these pros, these cons are there. And then we led to the choice of the couples to choose which one they want, because most of them, they say, I bought first manual, then I got another electric, then I got another electric. I have a bunch of pumps in my house. That's what they project nowadays. So it's better to tell everything. Let the choice get to the couple side to take a call on which one they want to choose. Yes, next. This is a cylindrical trigger squeeze pump. It's not available in market nowadays. It's completely out of market. Earlier days, I'm saying in 2008 and all, there'll be attender will be sitting opposite to the mother and they will be literally pulling the pump like this. They'll pull it out and do it. This is something like a manual one, and it's similar to that syringing method. It's very painful. Down the line, we had a complaints of mastitis and all by using this kind of pump, and also blocked ducts, lot of pain from the mother side. So this is not currently available in the market. But when the pump model is being formed, at that point of time, there was wooden pump, glass bottle pump, steel pump, and then only this model of BPA-free plastic started to come. Next one. Okay, this is the institutional pump. Institutional pump means the hospital-based pump will be there, where mothers can get the flanges alone and they can fit it to the pump and they can use it. This is more of a hygienic basis. Each mother has to get a different flange in use so that they could be protected from the infection from others. Earlier days, I'm saying 10 years back and all, they used to rent this pump. You have to give a refundable amount check like that of 1 lakh, and they have to pay every day 150 rupees or 200 rupees, where the mother used to hire this pump for a month period and all. It is still in practice in Western countries, but now in our place, it's still not practiced. They started to buy individualized pump more than renting. They find this to be beneficial, so they started to buy individualized pump. But this pump is really a kind of a boon only for the NICUs, I say, because for the time of amount they want to spend, this pump suctioning power and the way they give the pauses and all is really good compared to the individualized pump. But unfortunately, the flange size is not different when you get it. You get a standard flange size. So there are chances for the complaints for the mother side that it's paining for them when they use it. So again, depends on the mother's nipple and areola size. The flange size will change. So how to decide with the flange size? When you go with the flange size, the nipple has to go in between the tunnel of the that funnel. But when there's a friction is happening, that denotes that pump flange is not suited for the mother. So the pump flange starts from 19 to 30. 19 size to 30. Most of the pump companies will have 19, 20, 24. These are the three flange size will be generally available. But this is a standard flange size they used to give it to the customers. But they have to move with another size of 29, 30 means, because when they've been continuously pumping, there will be distinction in the nipple size and all. So they have to go with another size. When that option is not available means that whole pump goes for waste. So they have to buy another pump. So before they go buying with the pump, they have to look out whether that brand has a different flanges, and then if they could get that pump means that makes it work for them also. Next. Individualized automatic electric pump. Earlier, you moved the slide fast. Earlier slides. Earlier. No, you're moving forward. Move back. Yes, this one. So this individualized motorized pump is not to the par of institutional, but much better than the single electric pump. So there are people who travel from US tend to carry this pump. It's an automatic suction, double suction, and cost wise actually more compared to the individualized pump. Some others who have twins or triplets, they find it to be really useful, and they get the warmers also for them for the storage pack. Next one. This is another model of electric pump which is not in market nowadays. Next one. So storage guidelines. So most of the storage guidelines are being designed according to a Western country practice. But here we are in different temperature. When we come to our room, we'll be in 24, 25. When we move out, it will be 34, 35. So how to maintain a temperature? The first thing is the storage of the breast milk. Breast milk, the best material to store is glass containers. But because of the feasibility issues, whether they will break, when we transfer, there are chances of damage. Because of that feasibility issues, the second option which you can go is a stainless steel containers. But I still stick on with the glass material will be the best option to store breast milk. And if that is not possible, yes, stainless steel material you can use. The sterilization process will be 100% happening in these materials compared to these plastic bottles. Even though it is a BPA-free plastic, still my belief is it's not getting 100% sterilized compared to these two materials. So when they are storing in the room temperature, in sunny times, yes, we tell them to keep a storage of 4 to 6 hours in a temperature of 25 to 30 that time. And in case if it's becoming colder, that gets extended to 8 hours also. In a room temperature, this is what we tell them. Most of the mothers get scared by seeing that creamy layer coming up, thinking it to be a spoiled milk. But it's not a spoiled milk, it's not a homogeneous milk, so it gets that creamy layer on top. So we tell them to mix it up and use it. We make it very specific to keep separate containers for each pumping session, not to mix milk. And in case if you're keeping in the refrigerator, in the normal compartment, you can keep it for a day, because we are not having a dedicated refrigerator to store breast milk alone. We use our multi-purpose refrigerator to use for the breast milk storage also. So we don't want that to get infected. For that reason, we tell them to store it 1 day for the normal refrigerator. In the freezer, yes, if it's been a separate freezer compartment, you can keep it for 3 months period. And you have to label it up. So when you are taking the bottle or container from the freezer, the first container what you have pumped, you're going to take it out and you have to double boil it. That is a boiled water. Inside that you can keep this container. Once it gets thawed, when it comes to the room temperature, you can feed the baby. So can I restore that remaining milk inside the refrigerator? No, it's not allowed. Once you have taken it, you have to use it. You can't restore it again. Next one. So talking so much of breast milk, I'm not an ambassador for breast pump and all. I'm not endorsing for breast pump. I'm just talking the practical scenarios, what's happening in an everyday basis. I've just given this information. But there are adverse effects in regards to breast pump also. Because when they have been using a breast pump, they have been reported lot of microplastic has been ingested by these newborns. So what the baby takes directly from the breast and compared to the breast milk feeding, both are different. Because some mothers or even the attenders think, what is a major difference? Both are breast milk only, no? So anyway, instead of sitting and feeding, we can give express breast milk alone to the baby so that the mother can take a gap. So this notion is there. So we have to explain to the attenders mainly, telling them the composition of the breast milk keep changing when the baby keeps its mouth and takes breast milk compared to express breast milk through breast milk. And all plastic containers, when they are sterilized, again microplastic ingestion. So there are been reports of carcinogenic agents have been there. So this awareness, once it reaches, the usage of pump will not be becoming a normal one, but it will be a minimized usage will be there. Many people think when I go to work, I have to pump. I don't support that way. Instead, we just ask each individual's working hours and style, how it goes. So once they start with the solids after 8 months, we tell them to feed the baby and you can go and come back and you can feed. In case if you have a break time intermittently, someone can take your breast milk, come home and feed. Otherwise, you can come breastfeed and go. If that is not possible, no issues, come back home and by 5 o'clock or 6 o'clock, you can continue breastfeeding. Many people have a fear whether I'll get engorged. The body is so beautifully designed. As time goes by, the engorgement also gets delayed. If a mother is feeding every 12 hours or 13 hours once, she's going to get engorged in the 16th or 18th hour. So not required that every 2 hours once I have to pump to maintain the supply, every 2 hours once I have to pump to reduce the engorgement. This and all naturally it gets subside as time goes by, because by 7 month, 8 month, the day feeding time itself will become only 4 times or 5 times. I'm saying the whole day time itself will become 3 to 4 times. Only the night feedings will be getting extended. When these knowledges are imparted, the usage of breast pump slowly comes down, even for the working mothers, because it's not easy to use a breast pump in the workplace or the working scenario. But this has been blotted too much in the social media that if you're working, you have to pump. If you're working, you have to do this. Not at all mandatory. You can maintain without pumping and still do direct breastfeeding for 3 years, 4 years also, by continuing your night feedings before going to work feeding, coming back and feeding. Yeah, next slide. Yeah, improper flange sizes are being a major reason for having breast pains and nipple cracks. Some mothers have a lot of fear in breast pumps because they had undergone some crack or fissures on the nipples, so they think pump itself is painful. The pump not supposed to be painful at all. If it's painful, one thing, flange size is not being fitted properly. Second thing is either they kept it in a full intensity. The intensity should be kept in a way where it's not painful. But some mothers think when they are pumping, maybe my intensity is low, that's why my secretion is less. Let me increase my intensity so my flow will get increased. Please don't do that. So that will actually hurt the duct still more. Better to follow the intensity which doesn't give pain at all. Continue pumping in an interval of 2 to 3 hours once. If you pump within 1 hour, also it will be painful. There are some scenarios we have heard that mother been pumping for 1 hour, 1.5 hours. No, you shouldn't do that at all. You should pump only for 10 minutes per breast. That's all, not more than that. Some say if I do 10 minutes, I hardly say 10 ml container. It's okay. Pump doesn't do the work of the baby. Baby will extract more milk than a pump. So don't get depressed by seeing the volume. It is just a backup only. Doesn't mean this is the only option. And as they keep doing regularly, the volume increase for the preterm mothers. We counsel them in that way. Next one. Okay, this is called a haka bottle. So most mothers has a let down feeling happening. So when they are feeding one side, when this let down is happening, they can fit this bottle. It has a vacuum will be there. They just press it and they fit it over there. So the collected milk, they can use it for their babies. So instead of pumping everything, this is like a collection of the let down milk which is there. So this is quite useful for many mothers when they are feeding single baby the other side when it's sleeping. It's actually cost wise also is less, but useful for many mothers. Next one. Nipple shields. We don't prescribe nipple shields at all. Nipple shields prescription itself denotes hands-on skill was not being present in that scenario. When a mother doesn't receive a proper hands-on support on how to hold the breast or how to latch the baby, ultimately the immediate option it has been given is use a shield, it will be easier for you. But what happens is when you use a shield, the baby is being latched only onto the shield. The amount of extraction what the baby does will be very, very less, but the stimulation what the baby does to the mother will be more. So even though the mother is being lactating really well, unfortunately she is not able to deliver that to the baby. That's where the scenarios of mastitis and abscess cases goes up in this kind of shield cases. Thankfully, Breastfeeding Promotion Network of India have brought out this, and they have been very specific in their BFHA criteria, that is breastfeeding friendly hospital accreditation criteria, that they are not supposed to use shields and syringing techniques in their practices. The next image, what is there over there is called as a breast shell. So in case when the mother is getting heavily engorged, what happens is they're not able to latch on to the areola. So the areola also will become too hard. So they keep this breast shell in between that makes a depression over there that makes easier for the baby to latch. This we say as reverse pressure technique. So it's like when there's edema, when we keep pressing with our thumb, there will be dimpling happening. No, something similar to that would happen around the areola. So it's easier for the baby to latch on. So whatever milk collected in this shouldn't be used. It should be discarded as it's not been sterilized to keep it in that place. Okay. Next one. Yes, this method is again outdated one, not supposed to use at all. If you see that syringe where it is being placed, it's placed only onto the nipple. As you keep pulling it, there's a reverse method of again getting back in, and the tissues are getting damaged. Additions are there, sometimes it will get into tear, and there are many mothers who born with pus creation in that nipple area. I've seen a mother who completely lost her nipple because of doing this method. So this method is no longer recommendable. So some mothers get worried that what should I do in that case? We tell them to pump. So pump, you get dual benefit. One thing, you're going to get extract milk also. At the same time, aversion also happens. Again, when you choose with the pump, the flange size also is kept in mind, and they've been suggested based on their size. The flange size has been suggested, and they've been reviewed again after the long course of pumping session, because if you see, if you've been using pump for a long time, there'll be distension of the nipple happening. So we have to go with a different flange size after a long time. Next one. So feeding methods. So this method called syringe feeding method. The first image is directly placing the syringe inside the baby's mouth, and they are pressing it. So when this you start to do it, there's no control like whether the baby is taking or what, you just keep on doing it. So there are risk of choking or aspiration happening. So this is not a recommendable one actually. The second one is for babies who have sluggish sucking pattern. So for them, what they do is they keep a finger at the same time they have the milk dripping. It's like a drip drop method. Okay, so they keep it dripping over here. But what the problem is, your two hands are being full. You can't do it individually, and also at the same time you can't support the baby. So practically doing this is challenging. This second method also. Next one. So this is a universal thing which we see everyday practice. But Palada, according to me, is very comfortable within 30 days old baby. After 30 days, the major complaints is like baby is shaking a lot, it's like pushing a lot. It's very scary for us to feed in Palada. It's choking, sometimes it overflows, it spills all over. So when these fears start to come, then they slowly try to look out for other options of moving away from Palada. Another aspect what we have seen is babies who've been into long days of Palada usage, they tend to have a confusion when they come to breast. Once they come to breast, they'll be like the mouth only will be open. It's not close at all because their expectation is the milk will flow. I have to drink. It's not like I have to suck. So the transition, it's not from garage feed to breastfeeding. Actually, transition will happen from Palada feed to breastfeeding. So we have to sensitize the baby on understanding it. They have to suck and swallow. It's not an easy flow of milk coming. So long-term usage, I don't recommend Palada. Maybe within 13 days, okay. But later on, we have to move on with other option of feeding methods. Next one. So some will ask, can I give spoon? Palada is very scary for me. Can I give spoon? For a newborn, maybe 1 day, 2 day old, fine. When it's 5 days, 7 days, the demand is getting higher. The moment you take one spoon, by the time you move the next spoon, they start become very cranky, they cry a lot, they become very fussy. You can't handle them. They say, oh, baby is asking more. We are not able to feed consistently. It's getting very impatient by the time I take the next spoon. Yes, of course, it will become impatient because they've been keep on doing the sucking, but we are taking it very slowly by transferring from one spoon to the other. So constantly, as you're not able to feed, this is kind of a disappointing feeding method for the baby. Next one. So when these methods are failing, everyone's eyes fall on bottle. Why can't I use a bottle? It's a very easier method. No, I can switch over to the bottle. Everyone are doing it everywhere in media or in the movies. It's happening everywhere. What's wrong in doing it? So that's where we have to stand strong in telling them the impacts of bottle and how difficult for them to transit from bottle to breast again. And the breastfeeding duration also comes short because of bottle. Some mothers claim that my baby is feeding both. It's taking both breast and bottle also. There's no issues, they say. But suddenly one day they say, last 2 days my baby is not taking at all. Earlier and all it was taking, nowadays it's not taking at all. The reason is they got with the preference, not confusion. This is much better for me to take. Why we want to get into it? And the texture difference, the mother will be pouring out with milk, but still the baby will not latch at all because the texture difference, they start to recognize it. And they start to recognize the position also. The moment the mother places it near the breast, it starts to refuse. So breast bottle feeding disadvantages on health wise also, if we start to explain to the mother, of course no one is going to get into bottle. I always tell bottle is not required any time during the life of the baby. It can be switched over to, next slide, cup feeding. The first image, cup feeding. Cup feeding, this is a nifty cup, but you can do it even in the stainless steel open cup like that you can do. The cup feeding, once you start early, it can be a 1 month baby, 10 days old baby. Once you start early, you can continue even the baby's 8 months, 10 months, 1 year also. Transition to cup will be very, very easy. So the cup feeding method, the baby itself brings the tongue out and it will intake the milk. But when it comes to the other mode of feeding method, whatever I showed, it's only we are controlling what baby is not controlling. In a bottle, the oral action in feeding is completely different compared to direct breastfeeding. Direct breastfeeding, curling of the tongue and tongue comes out and withdraws it, everything happening. Compared to bottle, the tongue goes behind, it folds, they have to use the gums to bite it. So the bottle feed babies, when they come to breastfeeding, mother's complaint will be intermittently it is biting, it's paining. My baby got teeth, I think that's why it's not because of the teeth, because they're being introduced with bottle. Even for water, we tell them don't give it in bottle. Please try to use at least spoon or cup, but no bottle at all. So the second image over there, this is called the finger feeding method. Some babies who've been used to bottle. Okay, so we how to transit them to breastfeeding. So we first put them into this finger feeding method, making them to analyze that when you suck, the milk will come. We give them little bit like reward, like little milk coming out on its own. Once they start to get the flow, they start to suckle. Once they start to do the finger feeding really well, and then we transit them to the breastfeeding aspect. And even for babies who are preterm babies, who are babies who've been used to Palade are not transiting to breastfeeding. Those babies and all, this finger feeding works them really well. 2-3 days of practice, they are back to breastfeeding. Next one. This called SMS, Supplement Nursing System. So what is it is, we use this for relactation, induced lactation. So relactation is a mother who was sick or been away from baby, or they've been breastfeeding, she took a gap and again she want to get back for any multiple reason. It can be her breast milk or a formula. Okay, they'll be having it over there and it's been attached to the mother's breast and the baby will intake it over there. For an induced lactation, who's not been pregnant at all, adopted babies who gone through surrogacy and all, this method helps them to produce milk for them also. So they have to go through some induced lactation program before the arrival of the baby, 2 months to 4 months it. Most of the mothers were able to do 80% of breastfeeding for this induced lactation program. So this is a glass kind of cup, which you, next one. Next one, yeah. A glass one where you can start doing the cup. I'm sorry, you moved forward. Yes. So you can go with the cup feeding this way. So as I said, this method from day one, if you start, you can transit very nicely at any age of the baby also. So at the hospital setup, we are now trying to push with cup feedings more, so that even when they go back home, they're able to continue. So there won't be any confusion for them to get back to bottle or any other mode. And even when the baby is having solids, also having water will not be an issue at all. So we are trying to switch from palare to cup feeding. The other feeding methods have been tried and before going with the cup feeding method. Yeah, next one. Yeah, so when it comes for expression and feeding method, there's no one method which fits for all others. So parents and her circumstances, what are some being not able to breastfeed. It's not they are not willing to breastfeed. It's majorly because they're not able to cope up with the physical exhaustion to their baby's demand. So I always tell you have to be getting with more physical knowledge in raising the child more than the mental knowledge. So many times during the antenatal period itself, instead of just keep on talking the benefits of breastfeeding, benefits of breast milk to the mother and the father or the attender, we have to see how far they are physically ready to take it up. There are certain mothers who are not physically fit to get into exercises programs. It's okay. They can have their attenders planning. So when they have a single baby, who will be there to look after the mother and other core activities? They have to hire a maid if required. If it's a twin babies, they need 4 people, daytime 2, nighttime 2. So when this planning is there, yes, all mothers are able to successfully breastfeed without issues. But it's not being fortunate for everyone to avail that kind of a support system. The support system have been coming down. That's where all these kinds of properties and gadgets are stepping in. So we have to give them a backup support. It's not like we are deliberately pushing them to gadgets. When we tend to hear their family situation where the mother literally feels very guilty in doing all the bottle methods or other things, she wants to give breastfeeding, but when she's exhausted, we have to give a backup solution in that way where baby is being into breastfeeding without interruption only. All these methods have been discussed. And yeah, next one. Thank you everyone for this opportunity. I hope I made justice with my presentation. If you have any queries, please.
Any questions? Thank you, Jayashree, for a wonderful talk. Those suction bottles, you get it anywhere, is it? Those suction bottles for the left arm?
Hakka bottles, huh?
Hubba bottles.
Hakka bottles, now you get it in online only.
Online, Hubba bottles.
But you can stock it in your pharmacy if you want it, but it's an online.
Okay. That seems to be a different option. I think we should start learning cup feeding from you.
We did it for a 3-day-old and all, we did it both
Yeah,
together.
we do. Yeah, I know. But preterms, it's tough, right? It's a different.
Yes.
Thanks a lot for a wonderful talk, Jayashree. All of us
Thank you.
gained a lot out of your talk. Wonderful. Thank you.
Thank you so much.
So now we have the next speaker, Dr. Suresh Anand, our breast surgeon and oncosurgeon. Sir has got 27 years of experience in healthcare, both in India. He's trained in the UK. He's got he's a very knowledgeable and experienced physician or surgeon, I would say. So one big highlight about Sir is all his pep talks. I think all of us who work in Triple M know about Sir's pep talks. You would have had a bad day. You got up late. You had no gas in your car. You've had a hit or accident on the road, and you come and you see on the hallway. He'll say, "Hi, Shubha, how are you?" I said, "No, sir, don't say that. Why do you say that? Say you're good. Be enthusiastic. You woke up in the morning, your heart is beating, you're breathing. What more do you want?" He'll say. He'll talk something like that you will think, "Oh my God, I'm so blessed. More than Ambani, I'm blessed today. Why am I cribbing?" And then you go with so much enthusiasm back to work. So that kind of a wisdom he carries around, and he actually more than carry, he spills it around to everybody around us and makes us all feel so blessed in this world that we are still living around, not that no other cribs in life. So I think that also makes him such a well-rounded physician, because illness is just not physical illness, right? It's also mental. The mental manifestation of everything is physical illness. So I think all these spiritual knowledge which he shares with his patients, heals them faster. So I welcome Dr. Suresh Anand for his talk today.
Namaskaram, good afternoon to one and all. It's absolutely lovely to be here. Thank you so much for inviting me to this talk. Breastfeeding Week is the need of the hour. I don't think there's any other species on the planet which takes seminars on breastfeeding. Isn't it? We are the only species on the planet doing this seminar. So why are we doing this in the first place? Why is breastfeed much more important? Why? Do we want our next generation to be smarter than us? Better than us? Yes, that's it. So it's the quality that is most important. The next generation should be of a better quality than us. That's what every mother, every parent wishes, isn't it? They should be much better than us. And breastfeeding, it's got all the nourishment that we need for our brain growth and intelligence. So the topic we have today is prevention and early detection of mastitis. I see this all the time. Thanks for the lovely talk for Dr. Jayashree. She refers almost every 3 weeks. I see one patient with mastitis. So this is, I'm going to make it very short because in the interest of time. What are the signs of infection? What are the signs of inflammation? The 4 signs. Yeah. One is increased temperature, right? Fever. If any lactating mother has got fever, 100% you should be sure there is infection. It is not engorged breasts. 2, pain. Inflammation means pain. Pain can also be due to engorgement, but fever with pain means definite infection. 3rd, lump. When you have a lump. And 4th, redness. So when you have pallor, we have read it in pathology, isn't it? So when any of these 4 things are signs of infection, there is difference between, inflammation. The commonest cause for inflammation in the lactating mother is infection. And I would say every second patient I'm seeing with mastitis is a missed diagnosis. They have been misdiagnosed as breast engorgement or blocked duct. So this is the message I want to take. Please recognize early infection in the lactating breast. So if you see the breast infections, the commonest infection that we are seeing is during lactation. So 2/3 of the infection that I see is for lactating mothers. Of course, we see non-lactational mastitis as well. Every month I see one patient with non-lactational mastitis, and it is usually due to tuberculosis. Okay, so we are going to talk about the lactational mastitis. How do you prevent? I think we'll also talk about, I'll share my experience in Triple M with dealing with lactational mastitis and abscess and how to treat it and a few take-home points. So what is the reason why bacteria should enter into the milk duct and produce infection? Is there any bacteria inside the milk ducts in the TDLUs? Yes? No. There's no bacteria there. They're all in the skin only. We have 38 trillion bacteria in each human's body. And most of this bacteria is, where is it? Digestive system, oral cavity, skin, large bowel. So most of this bacteria are present in the skin, right? Oral cavity, large bowel. And you do not find bacteria inside the tissues, either inside the breast tissues or in the urinary system. Yes? So because we have a barrier, gut mucosal barrier, we don't get normally infection. So how does the bacteria enter into the breast ducts and produce infection? What is the commonest cause? Improper latching. So this starts from the very first time the baby latches on, the golden hour. It's the most important. And the commonest cause is flat nipple. If they have a flat nipple, then they have a problem with the latching. So if the baby, this is the proper latching position wherein, oh, I can't do this. Can I do this? Yeah, fine. As long as the baby's nipple is completely inside the baby's mouth, the sucking effect comes and there is free flow of milk. But if you have a flat nipple, yes, there will be improper latching. So there is abrasions of the nipple. So through these abrasions, the bacteria enter into the breast ducts. That's how the infection actually starts. So this is what it is. So we always have a cracked nipple. So when they have a cracked nipple and they have fever, 100% you can be sure it is infection, mastitis, right? What do you do next? We tell them put warm thing or ice packs or express them. No, they need an ultrasound scan and antibiotics. If you give antibiotics early when there is infection, within a matter of 2-3 days, the infection will subside and they prevent the abscess actually. Okay, and give something for the nipple. You can use some nip care or something like that so that it lubricates. So prevention and early detection of mastitis, it is in whose hands? Who's the primary carer? Huh? Newborn. So where at the time of delivery, the first, when they are here in hospital, that is the time. The first, most of these infections happen within the first 2 weeks of delivery. The other time we get lactational infection is during the time of weaning. So in between, when there is a free flow of milk, usually there is absolutely no problems. So the first golden hour, one is the latching, and the first day and the second day, I would say is the most important actually. So I'm putting this. Previously, I used to advise the patient if they have flat nipples, but now, as Dr. Jayashree said, no, right? With the other, they can use the breast pumps. So this is the, any two of this criteria is there, you should immediately think about infection. Don't just think about blocked duct or engorged breast. Okay, please recognize breast infections very early because there's something simple that you can do, right? You can start on antibiotics and you get an ultrasound scan. Right? So in our clinic, majority, 57% of people come with lumps, right? 77% come with pain. Of the lumps, if you look at the abscess, it's about 10%. 10% of the lumps that we are seeing in the clinic is pus. It is an abscess. Okay. So just give you an example. Typical scenario, what I see is postpartum. This is a 6 weeks postpartum with a 3 weeks history of a right breast lump. And examination, they come with a large lump. எல்லாம் முத்தி போகும்போது தான் வருவாங்க. They would have missed the early mastitis stage and they wouldn't have got a scan. So the bacteria is, playing havoc. It's just multiplying. That's good. Plenty of food is there. Yes. And once they become an abscess, full-fledged abscess, it's so traumatic to see the mother. They are actually almost in postpartum depression. So not only that they are not able to feed, they feel for the baby that the baby is not getting enough milk and they are suffering from the pain. They're suffering from fever. It's very difficult to see these mothers when they come with full-fledged abscess. This is totally preventable. This is totally preventable. Anyway, when they come, previously what we used to do, see when this ultrasound scan shows a typical, collection of pus. And when I was training and we're doing my MS, we take all these mothers to theater. எல்லாருக்கும் general anesthesia, then incision and drainage. And we break down all the loculi, then we put a corrugated drain and then hydrogen peroxide. Then we stop the breastfeeding, then pack it. It takes like 3-4 weeks of dressing. அதுக்கப்புறம் milk fistula. Now, all this need not be the case. You do not have to do surgery for a breast abscess. The simple way to treat it is, this is the olden technique, right? It's very, very rarely, it should not be used in this day and age. Simple way to deal with this is just ultrasound guided aspiration of pus, right? You can use a green needle. If you can use even a gray venflon if it is thick pus. You can irrigate it with normal saline. You can drain all the pus, send it for microbiology, and start on antibiotics. If they are multiloculated, they are more likely to be due to MRSA infection. In fact, I got some data. Almost 40% of the infections we are seeing, lactational mastitis, abscess, is due to MRSA. In that, if you give augmentin, Augmentin will not work for MRSA. What is the drug of choice for MRSA? Huh? MRSA, drug of choice. You have to prescribe it, right? Linezolid. Fortunately, this is one antibiotic. It is still sensitive to MRSA, actually. Right. So then you see them after, this is MSSA, methicillin sensitive staph. The common, almost 95% of lactational infection is due to two bacteria. One is methicillin sensitive staph aureus, other is methicillin resistant staph aureus. Okay. So you see them, they might require, especially the large abscesses, they might require reaspiration. Recently, doctor, you referred a patient who was delivered here, and she came, I don't know why she didn't come early. She came with a huge breast. The whole breast was red and inflamed, and it was pointing to the skin, ready to burst open. Still, we didn't take her to theater. Right? So we initially did an ultrasound guided aspiration, and it was MRSA. We just put some local anesthetic. Where it is draining, all when the skin is going to break open, we just put a small neck and just about 250 ml plus drained, just in the clinic. And she continued to breastfeed. Completely subsides actually. But you might have to do that a few times in the clinic. But there's huge benefits. It avoids general anesthesia. It avoids stopping breastfeeding. It avoids a scar. And it is very much economical. Otherwise, it will be 35,000, 40,000 for an IND. Yeah. So what is the incidence of this? So 1 to 24% of all breastfeeding women from the literature, and 5 to 11% of all mastitis progress to abscess, and it happens in the first 3 months of birth or weaning. And commonest cause is staph aureus, and 65% occurs in first pregnancy, primiparous women. So as I said, the advantages of doing ultrasound guided aspiration is avoids operation, no daily dressing, avoids milk fistula, outpatient treatment, can continue to breastfeed, and hardly no scars, cheap. So should we be doing open IND in this day and age? Yes? Okay. But most of the hospitals still they are doing open IND for breast abscess. So this is the message I want to take, that if they have, wherever the pocket of pus is, it can always have image guided aspiration of pus. Where even a subphrenic abscess, CT guided, we can put a pigtail catheter. Yes, you don't have to do open IND nowadays, because and there is enough evidence now. This is from our guidelines from the Edinburgh Protocol. So the few, if any, breast abscess require IND under general anesthesia. So this has been documented long ago, more than 15 years ago, actually. So if any of your friends, relatives, things with breast abscess, what do you do? How do you advise? First is imaging, ultrasound, get an imaging, see if there is a collection or not. If there is a collection, just put some local anesthetic, simple needle aspiration, send the pus for culture, start on antibiotics. Augmented is, we usually start on co-amoxiclav. It's a simple one. If it is multiloculated, linezolid. In 48 hours, we'll have the results. If it's MRSA, you continue on linezolid. Fine. So this is our data from 2009 to 2015. Mastitis was around 1/3, 33%. Abscess was 2/3, of which in our clinic, 2/3 is lactational abscess that we see. And we look at the MRSA rate, is almost 41%. The MSSA is 54. It still continues to be the same. And this is still old data. I would say now almost, I have not done an incision and drainage for the last, I don't know, for 4-5 years in theater. Everything we are 100% we can get resolution of abscess just in the clinic by ultrasound guided aspiration of abscess. What are the treatment you will give if there is MRSA? apart from linezolid? You have a lactational abscess, right? It's come as MRSA. What else would you advise in the treatment? They can be an MRSA carrier, right? They can be nasal carriers. They can carry MRSA in the axilla, the groin. So we always advise them mupirocin, tea-bagged ointment in the nostrils, both nostrils, twice a day for 1 week. And we prescribe lyso wash, which is chlorhexidine body wash. They can have a bath twice a day with warm water and lyso wash to get rid of the MRSA. Right? And then hand hygiene is important for them. So the other thing we always have to think of, supposing there is no growth on the pus, what will you think of? Huh? You have sent the pus for culture, there is no growth. Huh? Tuberculosis. Okay, this is the girl with the collection there. And yeah, there's no growth on the thing, but it is, we did a FNSC and that is shown granuloma, typical tuberculosis. Okay, this is tube. See, think of, we had lactating mothers with granulomatous mastitis. So that is one thing it should be on the corner of the mind, especially if there is no growth. You can easily aspirate the pus and do a core biopsy, you get a diagnosis. Okay. Treatment is still the same. I mean, only thing is we need to start on anti-tuberculous treatment, which is lactation is not a contraindication for AKT. You can give AKT when they are lactating. That is the guidelines. So one more thing you need to be aware. So this lady was taken to theater as an abscess, 25-year-old, right? It was all red and things. But then they found no pus. And they did a little biopsy and it turned out to be a inflammatory carcinoma. This is a so you have what you call PABC, pregnancy-associated breast cancer, which can occur during pregnancy and lactation. So especially with the current people who are postponing their marriage and pregnancy to a later stage. Yes, so we need to think of that on the back of the mind. So that is inflammatory carcinoma. So the take-home points are they need to be sensitized to encouraging breastfeeding from the antenatal visit onwards, right? And especially, as I said, the fathers. In fact, I went for an antenatal class my wife was pregnant the first time in UK. So they showed all the scenarios in how it will be in theater, nitrous oxide. So use the nitrous oxide, no anesthesia. So analgesia, all the different types of analgesia was explained. What is the role of father? How we can play a role? All these things. So it's very important to sensitize the couple in the antenatal thing, the importance of breastfeeding, recognize flat nipples, and recognize potential problems that might have during the lactational process, and see how we can help. Second, we need to if there is lactational problems, they need a help of a specialist. We have Dr. Shubha here and Dr. Jayashree and lactation consultants. Invaluable, actually. Invaluable. Because these mothers, I'll tell you, the trauma they go through. I don't know how you go through this motherhood, actually. I've seen my wife go through that. You know, I was with her throughout the delivery. They did the ARM, no? Just how much pain, how much pain. So, and she had to go through the forceps and this one, and then blood sampling from the scalp to see acidosis. It's a very, very, birth and death is not easy events. They're amazing, miraculous events. You need to cherish them. That's why this life is fantastic. Being born a human is so fantastic, isn't it? It's not an ordinary thing, right? Just to ஒரு sperm egg போட்டுட்டு here we are. Right. So it's very important. The message is please recognize infection early. Do not assume it is an engorged breast. Do not give them ottadam and say எல்லாம் சரியாயிடும். Blocked breast massage பண்ணா சரியாயிடும். No. If you have fever, if you have a lump, if you have redness, If you have pain, 100% that person has got bacteria inside the breast. You have to do something about it. Otherwise, they'll come to me later after 1 month with uvuloperia abscess. I don't want to see any abscess in the breast. Isn't it? Whose responsibility? Primary care, absolutely. See what you can do to empower yourself and people around you, sensitize them. So it's been a wonderful thing. So, the role of fathers, everybody should play their role, right? ஒருத்தரே எல்லாம் பண்ண முடியாது. Fathers, if they play their role, the midwives play their role, and immediately after delivery, that support that they get from the mother, from the in-laws, okay, we will have a fantastic generation. Next generation should be much far better than us, isn't it? So, and prompt breast imaging, please get an ultrasound. It's easily done, and you can do ultrasound, get an aspiration with microbiology. And majority, they don't need operation, just simple aspiration and antibiotics. Okay, thank you so much for your patient listening. Thank you.
Thank you, sir, for this informative talk. It was really good. So we have come to the end of the program. Vote of thanks by Dr. V. Geeta. She's a senior consultant obstetrician, gynecologist, and fertility specialist. I welcome you, ma'am, to give the vote of thanks.
So good evening, everyone. We have come to the end of the session. I hope you all had a great session post-lunch. So first of all, I would like to thank our head of the department, our Kundavi ma'am, for giving us this opportunity for this breastfeeding week. And we all are celebrating one full week with all Rangoli, quiz, and all these competitions. And I thank Marina ma'am for this organizing all these sessions. And I thank all our chairpersons and speakers, especially to start with Shubha ma'am and Dr. Anjali for the smooth running of the session, and breastfeeding for daddies, which was, welcoming speech for the session. I hope the message reaches for all daddies. And sir, பாபநாசமை விட நீங்க தொடுபுழா போட்டிருந்தா இன்னும் மெசேஜ் ரீச் ஆயிருக்கும். And sir, our Suresh sir, where he has got all the information and awareness about the mastitis, especially postnatally, how we have to care. And as he said, I've hardly seen any IND. Though during my PG, I've seen all. I used to tell all my patients better be care. So be careful about the abscess, breast abscess, because you'll have a nick, and healing that also would be difficult. But now we have Dr. Suresh for all those things. And thank you, Jayashree ma'am, for with all milk expression methods, she has expressed all the ways pictorically, and I hope the message reaches everyone. And all delegates, thank you so much, both online and offline, for the smooth running of the session, and especially our EDP team, and also our shield, Sahiti and Chitrakala, for helping us out for this easy zooming session. Thank you one and all.